Hello, folks. Can everyone hear me? You know what? I think our presenter could not make it, so I'm going to have to fill in for you folks. Okay. This is a CME activity provided by the Queens Medical Center, and we offer free CME credits for people who seek continuing medical education credits. And this is mainly for doctors and nurses. So you can go to the Queens Medical Center on-site location and look for your records if you choose to. I know most of you here are for the certificate of attendance, which we do that separately. About ECHO, this session serves as a forum for mutual teaching from different experts. The ECHO motto is all teach, all learn. So we all like to make this a community of learning. We're very open to your suggestions and comments, so feel free to participate. Our format today will be a short lecture followed by discussion. And please, if you have any significant experience, don't hesitate to share it. It just needs to be HIPAA compliant. Just don't review any kind of personal information and so on. Our team is our usual team is Wynette Gaylord, President of the Alliance of Residential Care Admins, Mary Tan, President of Foster Family Homes Association, Elsa Talavera, President and CEO of All Islands Case Management Corporation, Kara McCoy, our health coordinator for Aloha Care, Leila Ventar, who is the health coordination manager for United Healthcare, and Dr. Rita Bell Fernandez. Our speaker today is Ms. Martha Cloplin. She will be doing our topic today, Navigation Medicare, Part D. And Martha Cloplin is a Medicare subject matter expert and the syndicated radio show host of A Medicare Conversion with Martha and a Millennial. She is also a writer and has been published in the American Radium Society Journal and recently the Lancet Oncology. She also produces a weekly health-focused educational program on Olelo Community Television and is featured monthly in Living 808 on KHON2. Martha is a licensed general agent and financial planner, qualified professional since 1995, and also conducts quarterly Medicare pre-retirement workshops for several companies and nonprofit groups. Prior to transitioning to the healthcare industry, Martha worked as an assistant vice president for Bishop Trust Company and as a trust officer with First Hawaiian Bank. She is also a former vice president with Morgan Stanley, Dean Ritter Reynolds in Manhattan. She is married and has 2 children and enjoys sailing and reading. Okay, Martha, you can take it away. I'm going to bring up your slides next.
Okay. Well, thank you so much for that introduction. Can everybody hear me? Can you hear me okay? Guess that's a yes. Okay, I'm going to go ahead and start with the very first slide. It's called Navigating Medicare Part D, Prescription Drug Coverage. And just to let everybody know, I'm actually in New York City, attended my high school reunion yesterday. So I'm on New York time, but very happy to be with you today. It's many changes coming down the pipeline for Medicare Part D. both in 2025 and also some changes in 2026. So I'm really, really excited to, just take 20 minutes to just review some of these upcoming changes. On the next slide, I have my disclaimer, which basically I have to always make sure I tell people before these presentations that any information you want to verify, make sure you call Social Security directly or Medicare. None of the information that I share is intended for anybody to make a decision. Third slide. Can we pull up the third slide? Third slide. Not sure if there's a problem with the slides.
Martha, it might be slow. Let me backtrack.
Oh, okay. Okay.
Is it still stuck on your disclaimer slide?
No, all I can see is the very first slide.
And let me try reload it. Hold on.
Okay. Okay. Well, that looks good. So why Medicare Part, oops. Okay, next slide. So why Medicare Part D matters? Well, of course, it's essential for health. Prescription medications are vital for managing chronic conditions that are common, especially in geriatric patients. But drug costs are really, really rising and rising fast. So many people who are Medicare age or they have Medicare due to a disability, the out-of-pocket expenses are becoming a significant financial burden. However, there have been some recent legislative changes. One of them is called the Inflation Reduction Act, and this has brought many changes and updates to Part D, which is what we're going to talk about today. It's really important to have this knowledge because many geriatric patients or just Medicare patients in general, they don't keep up with these changes that can change as frequently as every year. So it really is important for anyone who touches Medicare patients who have Medicare Part D, they need to be aware of these changes. Next slide. Uh-oh, I guess we're slow again. Okay, so Medicare Part D helps cover the cost of prescription drugs. When a person has Medicare, if they're in the hospital, then drugs are covered under Medicare Part A as part of the hospital service. Also, sometimes people get certain injectables in a doctor's office or infusion center. That would be covered under Medicare Part B, as in Bravo. The Medicare Part D, as in drug, that's for medications that you pick up from the pharmacy. So it's also important to know that when you're talking about Medicare Part D or someone is talking about that, it's always medications that get picked up from a pharmacy used by the patient. Now, there are private plans that offer these Medicare drug plans, but every year they can change. So it's very important to be aware. Somebody might be prescribed a particular medication, everything's going well, and then they go pick up the medication and it's really super expensive. That could be because maybe that plan doesn't cover that drug anymore. So it's really important to understand that all of these Medicare contracts, including the ones that offer drugs, are subject to annual renewal. Now, there's two main types of Medicare Part D drug plans. One is called a standalone prescription drug plan. All it covers are drugs, nothing else but your drugs that you pick up from a pharmacy. Many people who use that type of drug plan will have original Medicare Part A and B, or original Medicare Part A only and a drug plan, or original Medicare Part B only and the drug plan. So that's the way that they get their drugs. Also, some people pick up what's called Medigap or Medicare supplement plans, and they will need a standalone drug plan because the supplement plan does not cover Part D drugs that you pick up from a pharmacy. There's also Part D Medicare Part D drug coverage that comes with Medicare Advantage plans that a lot of people are aware of. That's the type of plan that combines your hospital, your medical, and includes your Medicare Part D drug coverage as well. So my son says the Medicare Advantage plans are more like the cable package, everything thrown into one bundled plan. You get one card. You would use that card whether you're going for doctor visits, picking up your medications. So Medicare Advantage plan, that is the combined combo plan, comprehensive plan, all in one. The standalone prescription drug plans, people have to remember to show that card along with their Medicare Part A and B if they don't have a Medicare Advantage plan. Of course, there are costs involved. People pick up medications from the pharmacy. If they have a standard Medicare Part D drug plan and they do not get assistance from their state or Medicare savings programs, they'll have premiums, deductibles, co-payments, and also co-insurance. Next slide. Okay, formulary. Very important to understand the drug formulary. I get calls from people all the time who wonder why a particular medication, they go to the pharmacy and they doubt there's no coverage. When you have a Medicare Part D drug plan, not all Medicare drug plans cover the same medications. So it's very, very important to understand that you have to review that formulary and confirm that the specific medications that you have been prescribed are on that formulary before you enroll in the plan. If you're prescribed a medication after you've already enrolled, there is a process that you can appeal, but you should always make sure, or patients should always be aware, whether or not the drug plan they're choosing covers the particular medication that's been prescribed. If it doesn't, of course, they can reach out to their provider and ask for a substitute. So very, very important to understand the formulary. Now, when you have a Medicare Part D drug plan, there are different drug tiers. The medications are categorized into tiers and they determine cost sharing. I will tell you, a lot of people also are unaware that if you have a Medicare drug plan from ABC Insurance Company and you also have a different one, XYZ Company, they might have the same drug listed at different tier levels. Tier level 1 is your lowest cost for generic drugs. Tier level 2, also considered generic drugs, but will cost a little bit more. Tier 3 will be your preferred brand name drugs. These are sometimes subjects to deductibles and also have a higher cost. Tier 4 has a higher cost. These are non-preferred brand name drugs. And Tier 5 is the highest cost. Typically, your injectables, things that can be very, very expensive. And some Medicare Part D plans also have a tier level 6. So it's very important to understand Medicare Part D drug plans offered by different private insurance companies. They do not always categorize the medications under the same tier level. And even though the standard is 5, I have seen some plans with a tier level 6 as well. Now, there's also coverage rules that you need to be aware of, also known as utilization management. There's prior authorization. Sometimes somebody recently called me and they were prescribed a drug for weight loss called Zepbound, Zepbound, Zepbound. And they were surprised that it wasn't covered. In this particular case, their doctor needed to get a prior authorization from the Medicare, Part D drug plan, the company that offered it, because there was a particular diagnosis or condition that would allow their insurance company to cover it. But if the provider doesn't call for the prior authorization, then when you go to pick it up, it's a no. But if the provider does call and get prior authorization with this particular condition, that medication actually was covered. So you can really, um, you know, get a lot of bad information if you're not aware of how the rules work in the drug plan. There's also step therapy. Sometimes an insurance company requires the provider try a lower cost drug for the patient. If the patient has a very bad reaction or it's not working, then they will be allowed to possibly prescribe a different medication and the insurance company will cover it. But if you don't go through the step therapy process and that medication is subject to step therapy, then the insurance will not cover it. There's also quantity limits on medication, and I do have people who've called me to say, hey, I lost my medication and they're telling me I can't refill it. So it's very important to understand that there are some quantity limits on medication. So if you've truly lost your medication, there may be some ways around that, but you cannot exceed the quantity limits because that's how insurance companies manage these programs. Next slide. Okay, there are some key Part D changes in 2025. I don't know if anybody knows, but Dr. Oz is now in charge of Medicare. But some of these changes were already in place before he was appointed. But the Congress, I would say, and Medicare, they are trying to simplify the structure of Part D drug plans. So prior to 2025, they had something called the donut hole, and that was the part of the drug plan that a person had to pay 100% of the cost of the drug. So they now have eliminated that, and there are now just three phases to Part D drug plans. The first phase is the deductible stage. Second stage is initial coverage, and the last stage is the catastrophic. So they've moved from 4 stages now to 3. Some plans have an annual deductible. That's the amount that you have to pay first before the insurance company covers any part of the cost of your drug. For 2025, the standard deductible is $590. Now, does that mean every Part D drug plan or Medicare Advantage plan with drug coverage has a $590 deductible? No, they can be less than that, or they can be as much as $590. So that's why it's important to know how the plan works. Also, the deductible may not apply to the tier 1 and tier 2 generic drugs, but they may only apply to the higher tier drugs. So it's really important to study that Part D summary of benefits, and that is where all of this information will be contained. In 2026, the standard deductible is increasing and it will be $615. So, again, this is a new change for 2026. A lot of people are not aware of it, but that's what's coming for 2026. Now, some plans, again, may offer a lower or no deductible at all. So, it really is important to understand how your plan works. The way that you have a person learn about this is by reaching out to the insurance company that offers the Medicare plan, and you look at their summary of benefits, and that will have all of the information contained in this. So, very important to understand how these plans work. The exciting news that I think is on the next slide is last year, the maximum you would pay for medications is $8,000. That's changed for 2026 and will also be changed for 2020, 2025 and 2026. But I'm really excited about this one. This is a major benefit for our geriatric patients because they now will know there's a clear limit on their annual drug spending. What is that limit? 2025 total out-of-pocket costs for covered, operative word is covered Part D drugs will be capped at $2,000 for the calendar year. This includes the deductible, the co-payments, and the co-insurance. In 2026, that's moving up to $2,100, but that is fantastic because once you hit that cap, even if you take 50 different medications, the maximum you'll pay in 2025 is $2,000, and the maximum that you will pay in 2026 is $2,100. So I'm so happy about that. Now, once you reach that cap, you can keep picking up your medications, but you would pay zero out of pocket. So 2,000 is the cap for 2025, and that is a great financial protection for all of the beneficiaries out there who have very expensive medications. But the operative word is it must be a covered drug within that Medicare Part D plan, or if you have Medicare Part D as part of a Medicare Advantage plan, it must be a covered drug for these limits to apply. Next slide. Okay, another thing that I'm really, really excited about, and I know it's hard for people to get excited about Medicare, but I'm excited about a voluntary program that is available this year that spreads out the drug costs. And I've talked to a couple of people who signed up for this, and it really confuses them. But you do not pay at the pharmacy for your covered drugs if you call up your insurance company and say, "Hey, I want to join the Medicare prescription payment plan, MPPP, M triple P's, the Medicare prescription payment plan." It's voluntary, so you don't have to participate, but it spreads the costs out and helps a patient manage their cash flow by avoiding a large upfront payment. Imagine if you are prescribed a medication, like for example, I have some folks who take Prolia. And for the Prolia, that is a drug that is subject to a deductible in certain Medicare prescription plans. So they would have to come up with this $590 with that, first script. But in this particular case, the person decided to join the Medicare prescription payment plan. I called the insurance company with her because she said, "Heard of it? It sounds weird." So we called together, and she have to pay that $590 upfront. She signed up for the plan. It just took 10 minutes, or not even 10, maybe it was 5 minutes. And then they let her know that when she picked up the first medication, it would be that deductible divided by 12 months. So she was going to pay a lot less than she would have if she did not join the Medicare prescription payment plan. Now, they are going to allow anybody who participated in that plan automatic renewal in 2026, so you don't have to reapply. But this is definitely a wonderful benefit for any Medicare beneficiary with high drug costs, especially early in the year when that deductible often applies. I've even had a person, he takes a medication, Vindamax, very expensive medication, and he just is going to pay $166 a month, and that will take care of the entire script for the whole year and all of his other prescriptions as well. So I highly recommend, if you don't know anything about the Medicare prescription payment plan, make sure you look into it because it's very, very helpful for many of the people who've been calling me. Next slide. Okay, a low income subsidy, extra help. This can reduce the cost of medications for eligible seniors. The way that it does that is it will pay the monthly premiums, it will pay all the deductibles. And what's really cool, as of 2024, many individuals with incomes up to 150% of the federal poverty level will now qualify for these benefits. So if somebody didn't qualify last year or the year before, it's a good idea to have them call Social Security and request to apply for the low income subsidy. This program is also called Extra Help or Medicare Savings Program. So you have the numbers on this slide. They can call the Honolulu office if they're in Honolulu at 1-855-572-4879. Kapolei is 855-572-4866. And of course, they can always call the national number, Neighbor Island people, 1-800-772-1213. Next slide. I think we're almost done. Just a couple more. Okay, so what are some edible steps? Real quick, I'll go through it. Make sure your patients are reviewing their medications annually. Make sure that the formulary still covers those medications. I have a lot of folks have been calling me asking me about omeprazole. I hope I said it right. That's for tummy trouble. Medicare is not covering that now because it's over the counter. So I'm telling people, don't stress about it not being covered. Just pick it up over the counter. Very reasonable cost for omeprazole. Even though the doctor writes a prescription, it's okay. Just pick it up over the counter and toss the prescription. Also, it's important to understand the plan's costs, the deductibles, the co-payments, and that the new out-of-pocket is $2,000 in 2025, moving up to $2,100 in 2026. So you know your full cost for medications again that are covered. If somebody is still having difficulty, please look into that Medicare prescription payment plan, M with the three P's, and that definitely helps people. They don't pay anything when they pick it up. They get billed from the insurance company, and as long as they're paying their bill, they'll be able to pick up their medications. Also, check for that low income subsidy eligibility, also known as extra help. Annual enrollment period is coming. October 15th to December 7th. So this is a great time for people to compare plans and make changes. But I always tell people, if it's nothing broken, if your plan is working well, I don't care how many advertisements they see, stay put, don't make any changes. But annual enrollment periods are the time that people can make changes if they need to. And it's always important to know, don't hesitate to seek help from trusted resources or trusted sources, because sometimes Medicare can be a little bit difficult to understand. Next slide. Okay, here I just put on this slide just some resources. Of course, Medicare.gov is a great resource. 1-800-Medicare if you want to talk to somebody on the Medicare helpline. Every state has a state health insurance assistance program, free unbiased counseling. They should answer your questions. Also, you can reach out to Social Security for extra help and that low income subsidy. And also, please make sure people know it's okay to call their insurance company. The number for customer service should be right on that Part D medical insurance card. And people can always ask Martha. They can call and ask me. My number, my personal number is 808-230-3379. I give out my personal number. I encourage people to call me. I'm in New York today, but I think it's about 8:30, but you can always call me 808-230-3379 or text me and I will respond. I have actually talked to some people through this program. People have referred me from listening to the ECHO workshops, and they've been able to really do some great work with their patients. So that's the end of my prepared remarks for today. So I'm open to take any questions. Oh, I did want to just let folks know I also have this app. It's free. There's no advertising. You can text Medicare to 36260. Put this on your cell phone and very easily email me or look at the fact sheets or even listen to one of my radio shows or something like that. And then one more slide I think I have before questions. Next slide. Yeah, if anybody wants to listen to me on the radio, they can tune in to 99.5 FM on Saturdays from 2:30 to 3, or Sundays, they're locally in Honolulu on KHNR 690 AM, 94.3 FM dial. I think that's the last slide. Is there one more? Okay, and this is another app that I created. This is for people who have an Apple phone. We're still working on the Androids, but it's called My Digital Health Buddy. And this is just a way that you can, again, it's a free app, no advertising, but this is just a way to help people or even yourself if you want to have a device to put your insurance cards in, access your health records, look up coupons for medications, and also you can listen to my radio show if you have this app. So that's all I have for today, but I'm here and welcome any questions that you might have.
Thank you, Martha. That was great. Does anybody have any questions or experiences they want to share?
Hi, this is Melinda from Lokahi Case Management. I just have one question or maybe some advice. I came across with a patient or a member in a foster home that his Medicaid coverage actually kind of stopped because of pending 1147, and he needed a medication that so happened he doesn't have a Medicare. So is that, can the Medicare be initiated and applied for this particular member in order to get the Part D?
Well, Melinda, I believe it was. It sounds like your question is, this is somebody who does not have Medicare. He just has Medicaid, but he lost his Medicare? Medicaid?
Yes.
He lost. And does he qualify for Medicare due to disability or having turned age 65?
Yes.
Okay. So yes, in this particular case, this person could contact Social Security, get signed up for his Medicare Part A and B, or A or B, then he would be able to apply for a Medicare prescription drug plan, and this would provide coverage. So if this person does qualify for Medicare, then they definitely can pick up a Medicare drug plan or Medicare Advantage plan, but they must first make sure that they have Medicare A or Medicare A and B or Medicare B only to pick up a drug plan.
Okay. What is the turnaround of them be able to approve for Medicare?
Well, it depends on the workload, but also what I do in my practice is I help people understand how to correctly fill out the form. So when Social Security receives it, they can turn it around pretty quick. So when I've helped people, it's been pretty quick, maybe 2 to 3 weeks, but sometimes it can take up to 3 months to get your Medicare approval. And that's shown on the website. Start 2 to 3 months early. But if you have the paperwork filled out correctly and the person indeed qualifies, it can certainly be shortened. So if you want to reach out to me, be more than happy to help you.
Thank you.
Any other questions?
What was the
I-
first
Hi,
app
Martha.
that you mentioned?
I didn't hear that.
Whoever
They
asked
wanted
that
to see
question, please
the
repeat.
first
Thank
app.
you.
You need the first
There,
app. Maybe you could roll
yes.
back the the um, the PowerPoint to that page with yeah, the one before that, right? It's one before that. Oh, one more back. This one. So this, yeah, this one. You can actually, like a text message, like you would send to somebody, you could just text the word Medicare to 36260 from your cell phone, and then you just follow the instructions to download it to your phone, and then you're able to just, whatever new information I have up there, I refresh it every couple of months, but I put a lot of Medicare information on this site. So you just text the word Medicare, like, you were texting, hi, friend. You just text the word Medicare to the number 36260 from your cell, and that should put this app onto your cell phone. And then whatever you want, you just tap it. Whatever I have up there. I have different things, different months.
Hi, Martha. Does this app have information on about care? Like, if I wanted to learn just the basics, is that, they learn the ABCs of Medicare? Okay, I see it there.
Right. So I do refresh it sometimes. So when you go into it now, I might have taken that down, but I have something else, on there. You can go to Medicare.gov as well if you want to learn, but I always put things in there, like it says Medicare New 2021. So I've refreshed that already. But you can always go in and find information that I have about Medicare, because I love I love this subject very much. So I love pointing people to resources that I think are very helpful.
Great. And something that I came across in kind of preparing for today's webinar was that there's possibly penalties for late enrollment. Is that something that's true?
Yes, that's a great question. There are late penalties if you don't enroll when you're supposed to. And there's also specific enrollment periods. I just had a person who decided never to, he wasn't going to get Medicare. So he didn't pick up Part A, B, or his Part D either. So it's 10 years later, and he needs to pick up the Medicare Part D, and he did, but he's paying 30 cents for every month that he should have had a Part D plan from age 65 until the present time. So it's a pretty significant penalty. It's every month for as long as you have Medicare. So there are penalties if you don't pick up Medicare Part D or Medicare Part B during the, designated time. Yes.
What do you think is the number one mistake that people who are eligible for Medicare make? Do you find like there's patterns and common mistakes that happen?
Yes, there are common mistakes in the enrollment in Medicare. And I would say the most common mistake, and believe it or not, uh, physicians, dentists, chiropractors, physical therapists who have their own independent practice, they make this mistake. When you turn 65, even if you have an employer group plan, you have an employer group plan, but you have less than 20 people working for your company. Again, independent practitioners, you are required to pick up Medicare uh, Part B, A and B, and a drug plan at the age of 65. If you don't, you can end up learning if you have a major illness that Medicare was supposed to be primary, your employer plan would be secondary. So the employer plan does not have to pay for any of the care. The biggest mistake is people do not understand the specific time that they need to enroll based on their specific situation because this information, I guess, is just not really made readily available. How many times you turn 65 in a lifetime, you know?
Yeah, I have a member who I work for Aloha Care, so we have our Advantage plan. And I have a member who swears
Yes.
by staying on original Medicare over switching over to our Advantage plan. Is there, she's given me her reasons, but from your point of view, is there is that a good thought process to have? There's no convincing on my end she will not move over, but I just kind of wanted to know from your point of view what the advantages are for her to stay on the original.
Right. And that's a great question. You know, what are the advantages for staying on original Medicare and not joining a Medicare Advantage plan? First, let me just say that I think that one of the reasons that people really stick to their guns is because of TikTok videos and Instagram and all of this stuff floating around. A lot of folks who are attempting to influence people for their own reasons will say Medicare Advantage plans are all bad and stay with original Medicare because you won't have as many problems with pre-authorizations. However, there are many drawbacks to just keeping original Medicare. There's a lot of additional benefits that you don't get. I'm actually out here in New Jersey. This is so interesting you would bring up that question. And one of my friends that I visited with, she said, "Oh, my sister-in-law has original Medicare, Medicaid, and that's it. And she wants to have, utilities and all these other little things she hears about, but she wants to stay with her original Medicare. She just didn't realize that in order to take advantage of some of the other benefits beyond what original Medicare pays, she needs to join the Medicare Advantage plan. So I think it's really just a lot of misinformation out there. You know, original Medicare can work, and especially when you have Medicaid. The state is paying your co-pays and co-insurance, but Medicare Advantage plans also have many benefits.
Am I the only one who can't hear, or did the audio go off?
It went off.
Audio went off.
I think it's a delay. It's the connection.
Hi, Martha.
Yes.
Okay, now we can hear you. Go ahead. You're going to have to repeat about the last minute of what you were talking about because there was a glitch in the system.
Oh, okay. Yeah, I was just
Thank
saying
you.
that I think it's a lot of misinformation out there. A lot of people are being told to stay with original Medicare and avoid Medicare Advantage plans. But Medicare Advantage plans, of course, pay benefits above and beyond what original Medicare offers. So in order to take advantage of these things, you would need to join a Medicare Advantage plan. But I think it's just a lot of misinformation because I have seen a lot of videos out there that are telling people to avoid all Advantage plans, not just duals, not just any one particular insurance company, but to avoid all Medicare Advantage plans and stick with the original Medicare. And I actually have people calling me now saying that as well. I always educate people and I tell them, listen, don't do it based on a TikTok video or something like that, but really make sure you study and you figure out what's best for you. Because when you're getting service, whoever is telling you don't do this, don't do that, they won't be there with you. So you want to make sure you understand how it works. And like I said, I had a friend out here in New Jersey whose sister-in-law had original Medicare. She just got approved for Medicaid July 1st, and she wasn't planning to join a Medicare Advantage plan. She had a separate Part D drug, but I looked at, they said, hey, can you take a look at this? And I took a look at the dual plan in New Jersey. And it was a great dual plan that would give her food credit, utilities, a whole bunch of things. So she is, going to move to that. But it was just interesting that this friend, her sister-in-law, had the original Medicare, the Medicaid, and a separate drug and did not realize she could get additional benefits from the Advantage plan.
And I was present last week when you presented to us with Aloha Care, but can you go over how the state is changing with having both Medicare and Medicaid with the same company with the Advantage plan?
Yeah, that's a great question. A lot of people may not be aware that last year and the years before that, if a person had Medicaid and Medicare, every 3 months they could just kind of change their Medicare plan. But starting, January 1st, 2025, that quarterly opportunity to enroll in another plan is over unless you're going to make sure that your Medicaid insurance company and your Medicare insurance company are the same. So if you are joining a Medicare plan in which they have your Medicaid piece, you can do that, but you're not going to be able to, if you have HMSA Medicaid and you want, somebody else's Medicare, you're not going to be able to do that any longer this year. You have to align your Medicare and your Medicaid together. That's a special enrollment period, but you won't be able to just keep mixing and matching, because what the state wants, and I can understand it, they want everything to be very fluid. They want, claims to be processed very easily. And when you have your Medicaid with one insurance company and your Medicare with a different insurance company, there's a lot of coordination that has to take place. So it will definitely be a lot easier to manage patients if their Medicare and Medicaid are with the same insurance carrier. We got a call just last week when I was doing that Aloha Care presentation that week, and there was a person who had Medicaid with one insurance company, and she had her Medicare with a different insurance company, and her claims were not getting paid. It was just awful. So she said, you know what? I realized I got to go ahead and align my Medicare with my Medicaid, because she said she's on hold and they're trying to fix it and it was just unfixable. But if she was aligned, everything would go smoother. So in 2025, people can't keep changing their providers. They have to align, make sure their Medicare provider insurance company is the same as their Medicaid provider.
So, Martha, this is
That's new.
Melinda. So, does that mean when the patient just newly enrolled in Medicaid, because there's this thing about sometimes they're all auto-enrolled, they didn't even choose the insurance. So, is that going to be communicated between the Medicare and Medicaid?
Is what going to be communicated?
Because sometimes the patient already, for example, have a United Health or UHC or Aloha, and then when Medicaid process for LTC get approved, they're automatically enrolled whichever is open for insurance. So they're not going to be aligned because MedQuest sometimes will enroll them to a different insurance. So is there a communication between the two?
Right. So what had been happening is when a person qualifies for Medicaid, we have, 5 different managed contracts. There's 5 different managed care contracts with the 5 players. So they would just distribute those people to those players. But when the person has Medicare, okay, they have Medicare, a Medicare Advantage plan. Now what they're looking to do, I'm sorry, when they have Medicaid and they're looking to put them in a Medicare plan, they're able to put the person into the same Medicare plan as the Medicaid managed contract. So don't think you're going to see that anymore, where a person, let's just say they have Aloha Care Medicaid, Aloha Care has a Medicare contract, so they're going to auto enroll that person into the Aloha Care Medicare contract. They're not going to put them in a United Healthcare plan. Only the patient will be able to do that. So what you're going to see is the state is also doing alignments. So if they have a person, again, in an Aloha Care Medicaid plan, they're going to put them, into Aloha Care's Medicare Advantage plan. The state is allowing that. And I do have the documentation on that. If anybody, wants to see that, I actually have the specific state, change that speaks to that they will be aligning the person's Medicaid with the Medicare, because all of the contracts that the state of Hawaii has with each insurer that does their Medicaid managed plan, every single one has a Medicare option. So that person will be automatically enrolled into the Medicare contract starting now when they qualify for Medicare after having been on Medicaid. So it's happening. It's here.
Okay. Thank you for the info.
Yep.
Anybody else have any questions or experiences they want to share?
I'll just jump in. I really do love helping with the little sticky problems that come up. So please feel free to reach out to me. I do it as a community service. I don't like to hear of people suffering when it's just an information glitch. And a lot of the challenges that I've been, helping people with is something that I can clear up very easily. Just takes a text or a phone call, and I do get back to people and I do help them. And I've helped quite a few people from doing these presentations. People called me and we're like crying because we're able to help somebody that was in a really bad situation. And it's very difficult today to find people who can help with specific situations that are non-routine. I've been doing this for 15 years, so I've run into so many things that I can pretty much like, what? Oh, I know what that is. Here, do this, make this phone call. So I really do enjoy helping, and I believe that, in our little small community, we got to work as a team. And wherever there's information and somebody willing to give it, let's work together. So I just want to say that.
Well, undoubtedly, that was a lot of information that you covered, Martha. Thank you so much for taking the time today and giving us so much information. I know it was a lot for me myself to absorb. So I'm the worst person when it comes to Medicaid, but I appreciate the information as a whole. We do want to send out a special invitation. We have an organization, obviously ARCA. So I'll be contacting you directly, asking you to be a speaker at one of our educational conferences in 2026, if you don't mind.
Oh, sure. And I can always slow it down, but I always feel like I have to keep it to 20 minutes. But I could always slow it down and cover something smaller. But all of this information, it is a lot to absorb. So no one gets it the first time around. 15 years, I think I got it.
It definitely sounds like you have all the information down to a science.
Thank you.
Thank you. John, do we have some slides that you want to present, John? So wrapping it up today, we want to, number one, thank all of you for attending the ECHO series. I'm Juanette. we have some medication evaluation slides to go over, and I just want to explain everything to you. Again, we need to complete these so that you can go ahead and get your certificates. It will be automatically emailed to you after you submit your evaluations. Number one, the first slide, the number of residents that you have in your care home. So only the PCGs or the care home operators, foster home operators are going to be the ones that complete this slide as far as medication evaluation. For resident number one, you want to fill it in with the resident that's been with you the longest. So whoever out of your 1, 2, 3, 4, 5 residents that you may have, it would be the one that's with you the longest, first admitted into your home. Then we'll go on to the questions. They're asking, if the resident has been prescribed medication for pain, has it been reviewed by a doctor? Yes or no, non-applicable. Again, if the resident has been prescribed medication for sleep, has it been reviewed by a doctor? Yes or no, non-applicable. If the resident has been prescribed medication for agitation, has it been reviewed by a doctor? Again, yes or no, non-applicable. Has a brown bag medication review been performed? Yes, no, not sure. Was the medication list updated? Yes, no, not sure. Again, we go to resident number 2. That would be the resident that has been with you the second longest. And then again, you have resident number 3, 4, and 5. And please do take the time to complete this medication evaluation. Submit your evaluation to get your certificates. John has already put it in, I'm sure, the box. Anyway, to receive a certificate of attendance or CME, please fill the evaluation. Click on the link in the chat to enter the evaluation for a certificate of attendance. Click the certificate of attendance choice near the bottom after you enter the evaluation. The certificate of attendance will go to your email. Check your spam folder if you don't see it. The evaluation must be filled in again for each person in your group. If you have any questions, you can email me or you can put it in the group chat. But definitely appreciate everybody for attending today, and have a great rest of the week and a restful weekend. Mahalo and aloha.